Good evening, everyone. We welcome you all to Ortho TV Online Nucoxia Digitalk series. This webinar is brought to us by an unrestricted educational grant from Zydus Cadila, the makers of Nucoxia. We have today our esteemed speaker, Dr. Raj Shekhar KT, and we have our esteemed panelist, Dr. Salim Patel, and he is going to introduce the speaker and the topic for today. So over to you, Dr. Salim.
Yeah, thank you, Neeraj. So, good evening, everyone. Welcome to Ortho TV for this Nucoxia Digitalk. Our speaker for today is, as Dr. Neeraj has already mentioned, it's Dr. Raj Shekhar KT. He's a senior orthopedic surgeon and a joint replacement surgeon at Fortis Hospital, Bangalore, with over 20 years of experience and fellowships to his credit in the name of Dr. Ranawat Center in USA. Then in Mumbai with Dr. CJ Thakkar. He has been an awardee for Dr. Dholakia's Best Paper Presentation Award at the ROC 2016 and 18 on a topic that is lateralization of the femoral entry point in TKRs in a bored femur. The same award was again received to sir at the American Academy of Hip and Knee Surgery in Dallas in November 2016. He has n number of publications in both national and international journals and has written multiple chapters in various textbooks in orthopedics. Sir is an esteemed member of the Indian Society of Hip and Knee Surgery, the Indian Orthopedic Association, Bombay Orthopedic Society, Karnataka and Bangalore Orthopedic Society, and the Indian Arthroscopy Society. So today, I hand over this session to Dr. Raj Shekhar KT, who will be talking about TKR in a varus knee. So over to you, sir.
Okay. This Salim, I think you should stop.
Yeah, I just stop share, sir. Yeah. Yes, sir. You can go ahead.
Yeah, thank you, sir, Dr. Salim and Dr. Neeraj. It was a great pleasure to speak on this topic at this point of time. And just go to directly the topic. Just wanted to speak about the alignment in a board legs. If you're doing a conventional total knee, as all of you know about the board legs, and sometimes those who are used to that knee replacement with a conventional technique, it is little difficult and tricky. So how to get the proper alignment? Unless you have in your center, it is navigation is there or other techniques you can use. But if those things are not there, at least I can just share my experience and you can make use of this and you can get the good alignment. So the post-op alignment is very important and there is enough literatures and everyone is aware of this. And otherwise, if the alignment is not good and this leads to aseptic loosening of the tibia. So the aseptic loosening of the tibia is very common, more than the femur. Again, there are enough literatures showing that the aseptic loosening is common with if it is a varus alignment, either because of the femur or the tibia. So ideal alignment is 4 to 10 degree of valgus achieved with 75% of cases only. This is published by Malakshmi, and remaining around 17% either there will be a varus and around 1.9% cases there will be a valgus alignment. So the varus tibial alignment was associated with 3.2 times high, greater risk of failure in a TKR, that is studied by Fang et al. So this is what tibia bowing I was talking about. There is a higher incidence of we have seen in Indian patients both the femoral and tibial bowing, and leads to osteoarthritis, and because of the maybe long-standing osteomalacia leads to varus alignment. So the bowing is defined as the tibial bowing is defined as anything which is bowing which is more than 5 degree. I consider as a bowing which is milder degree. The bowing is nothing but the lateral bowing of the distal axis angulated towards the midline. So the extramedullary guide is ideal method to use tibia, but hardly few people are using intramedullary technique. But if you use the intramedullary technique, there is problems with this technique. I'll just show you. The present study I just wanted to mention about this tibial accuracy, how to get the accurate alignment in the varus knee, is that because of the bowing, if you use the intercondylar eminence as a reference point, it might lead to varus alignment. So what we hypothesis is that based on the degree of the deformity, we can use the lateral condylar eminence as a reference point, and you can use get an accurate alignment. So we have studied around cases of around 163 cases. There were 240 knees, and in that both TBI is 62 patients, and in that case, the number of knees around 95 knees with an average age of 64 years and mean follow-up of 3.4 years. We have seen that Boeing is seen in all these patients around the incidence is around, say, 38.3%. The selection criteria of Boeing is especially the patients with osteoarthritis with the coronal plane deformities. The exclusion criteria, if there is a post-traumatic knee arthritis, either because of the tibial condylar fractures or monotetibial plateau fractures, or the revision knee replacement where there is a varus deformity. So that Boeing is measured with a preoperative scanogram. Here is a picture showing, and then in that case, we draw a line from along the medullary axis. So you can see this is the medullary canal axis. This, and you draw a line from the center of the intercondylar eminence, perpendicular line from the center of the tibia distally. Then join these two angles. Where is the angle? That angle gives you there's the deformity of the tibia. So suppose if this angle is around 8 to 10 degrees, then you draw a line from the distally, just pass it from the distally, go straight to the lateral tibial eminence, where it comes from the intercondylar eminence to the laterally, how many millimeter is coming? Say around 8 to 10 millimeter means 8 to 10 degree bowing, usually 8 to 10 millimeter. So that amount of lateral reference you used to use, that I'll show you on table. So the best method in this case is we need to avoid the patella, dissect out the lateral part of the tibia where we are going to place the jig. So once you place the jig, you mark the intercondylar eminence as a reference point first primary. Then from there you can say 10 millimeter, let's take the lateral eminence as a reference point. Then your center of the tibia jig should place on the lateral area. From then you put a pin and connected, we can put the rod if you want, or you can eyeballing, you can see where is your alignment. So you can see this is a perfectly going center. So adjustment we can put, and we can put the other pin. With this, if you cut the tibia, your accuracy of the tibia cut usually very good. So in our patients, the bowing of the tibia in 70% of cases is 5 to 8 degrees, and 26.3% of cases is 9 to 12 degrees. More than 12 degrees in 3 tibia, around say 3.2%. So in this method, we are able to get an nearly accurate alignment in all these patients. And there is significant improvement in the knee score. I don't think that the knee score had any value in this case. This is maybe the helpful in case of post-operative long-term alignment. So the post-op mechanical axis is within 3 millimeter in 70% of cases, more than 3 millimeter on the medial side in 26% of cases, and more than 12 degrees in more than 3 patients. So the post-operatively, we are able to get accurate alignment of the tibia around 6 to 10 degree of valgus alignment in 94% of cases. There was no lateral overhang of the tibial implant. So the linear aggression analysis shows that there's a positive correlation between the bowing of the tibia and the lateral reference point. We can use the internally rod, but to get an accurate alignment. But problem is, in Caucasians knee, they can use it because of the straight tibia. But in our cases, because of the bowing, we are not able to insert the tibia, and then can give, it gives an error. Intramedullary guides in Asian patients, they have done studies showing that more than 20 error rate is more than 20%. It can cause error in the tibial cut, and because of the difficult to pass the intramedullary cord along the length. And you can use a short rods, but if you use a short rods, again tibial cut alignment changes. So the extramedullary guide technique is the best thing, and it gives you an accurate alignment. The technique is only, as I mentioned, if you use the technique, you can use. There are different techniques which is they use the center of talus as a reference point. It's difficult to precisely get the talus, especially in obese, bulky ankles. And tibialis anterior is also the same thing. It's difficult to palpate sometimes under anesthesia and obese patients. And computer assisted surgery, we can use as an accurate alignment to the tibia, but again, the error rate is, again, it depends upon your registration. If your registration is wrong, it can cause tibial cut, either varus or valgus, and it is not available everywhere, and it is time consuming and expensive. Patient specific instrumentations have not been uh, very supportive, the literatures, and they come and gone, and they're costly and time consuming. So Takamani et al. Showed that in Asian patient with the varus deformity with the bowed tibia, the most of the time the center of the tibial plateau is either usually the medial. So the lateral tibial condylar eminence is the center. So maybe you should use this reference point, use an accurate alignment. So comparison the two methods we can see here, where the center of the intercondylar eminence is used as a reference point. We have 87.7 degree varus. There is a tibia slightly in varus. You can see this is in lateral condylar eminence is a reference point where the alignment is almost 90. So Kim et al. Showed that in the sawbone model, the tibia resection in varus deformities to the acceptable degree of alignment was achieved when using a lateral condylar eminence. So in our study, the lateral intercondylar eminence acts as a reference point, and we used it, and it gives a really accurate alignment. So in conclusion, it's a simple, reliable, easily reproducible, not reported earlier. We can get an accurate alignment of the tibia bowed, especially in bowed tibia, to get an accurate alignment of the tibia. We published this in Journal of a Korean journal, and this is about the tibia. I'm just going to speak on the femur. You can see the femur is how they are bowed. So how to get that accurate alignment in this case if they don't have navigation or scanograms. So what we have to do is either just take on full length femur if you don't have any scanograms. With that, we can get a really rough assessment where we can assess this bowed tibia, and we can measure the angles. The bowing of the femur is being reported insignificant in Asian patients, and bowing is also reported in Western population in 14% of cases. How they come to know is when they're doing it, then they used to assess the CT scans of all these patients. And in that case, in those patients, around 14% they show that femur is also bowed in these occasions. So the variation in the distal femoral cut is around between the 84 to 115 degree. That means there is so much variation is there. It is being reported by Malek Singwala. The incidence of potential error of unacceptable femoral cut is as much as 40% with the femoral bowing. Suppose if there is a straight femur, it is only 8%. So the propensity of errors of the distal femoral cut is high in these cases. So they recommend to use either extramedullary jig or computer navigation. Extramedullary jigs is because of the bulkiness, and they are not very accurate, because to get the idea of the center of femoral head is difficult. So we use this technique of intermediate jig in case of Boeing is that if you use a conventional entry point, this rod is going to hit the lateral cortex, and then you end up in using a short rod, and that leads to undercutting of the deformity. So when you little lateralized based off your bowing, say around 8 degree, if there's a bow is there, you lateralize by around 8 degree, 8 millimeter, you can able to reach the isthmus and you can get an accurate alignment. So from Jan 2011 2014, we have done around 136 cases. So in that we have seen is 44.9% incidence of bowing. So the bowing percentage in our patients is 44% 9 cases, and an average BM of 29.9, and diagnosis almost all patients are osteoarthritis. We are not including any post-traumatic cases in this our series, and mean follow-up of 3.2 years. So what is bowing? Bowing is defined as the distal axis is moved towards the midline and the shaft is bowed on the left side. So we have included osteoarthritis, as I told, and post-traumatic arthritis, deformities of the femur, with old fractures, revision to total knees are excluded. And you can see here the bowing as defined as described by the measured with the help of method which is described by Mulaji et al. Earlier. And the preoperative scanograms is very important. Either the X-ray scannogram or CT scannogram you can use. If you don't have all this facility, either you can just take the full length femur where you can measure this angle. This is an example I'll show you. See, this is a so much bowed femur. So bowing a femur is almost, you can say 13, 14 degrees there. So normal conventional jigs, if you use a central intermedullary reference as a point, this 13 degree, you can't cut the distal femur because the maximum distal femur cut angle we can get is only maximum is 9 degree with the conventional technique of our jigs. So how to get that 13 degree correction? So what we can do is if you little lateralize maybe 9 to 10 millimeter, and then you are able to reduce the angle of correction instead of 13 degree, we can reduce to 8 degree or 7 degree as I shown here. With that, we are able to get reasonable alignment, and we can cross check with the post-operatively after correction intraoperatively by passing the rod from the center of femoral leg to the center of ankle where it is going with the balancing. So in this case, see, this is what the intracondylar eminence is the center point isthmus, and we are lateralized around 8 to 10 millimeter. So this is a lateral entry point, and you can see this is within the box cut. So we are not going out of the femur, and you can see there is a femur component. There is no overhang of the implant, and there's a box cut wherever this lateral entry point is coming within that this thing. So this is a technique where we used a conventional technique was used in the left side, lateral entry point used on the right side. So you can see this accuracy is the mechanical accuracy is going center right exactly in the ear on the right side. Lateral side you can see there is a varus alignment. It's another example. So in these our series around 5 to 8 degree bowing is there in 48% of cases. 9 to 12 degree bowing is 44% cases. More than 12 degree is 68% cases. And in that, the post-op axis is within 3 millimeter in 48% of cases, and more than 3 millimeter on the medial side in 8% of cases, 1% of cases more than 3 millimeter on the lateral side. So nearly in almost 90% of cases, your alignment is within reasonable with a good alignment and pre-op and post-op functional good scores. As I told, this is a 4.5% at a varus tibial femoral angle, 2.3% as a valgus, and 93% of cases we are able to get reasonable alignment. So linear regression analysis shows that the positive correlation between your bowing and the lateral entry point. So Lee et al. Showed that there's a maximum incidence of malalignment with the bowed femurs. So chassis will be useful in such cases. Not all are able, is not available easily because of a cost and a learning curve, and there is a slight increase in the operating time. The patient-specific instrumentation has not proved its effectiveness in so especially in knee surgeries. So that's why the cost-effectiveness PSI has been also questioned, and that's why it is not nobody hardly people are using this. The extra-articular osteotomy, it needs two surgeries correction, two surgeries, increases the morbidity. So current instrumentation system, as I told this, where you can see this is a red color, where a 12 degree is showing. Just 1 second. You can see this is a 13 degree with a red color. If you moment you lateralize it, it reduces to 8 degrees. So that's the advantage, and you're able to get reasonable alignment. And you can see this entry point is well within the box cut. Problem with the lateral entry point is if you go more than 10 meter, then it can lead to defect in the lateral condyle and the medial part that needs to be bone grafted. We have done bone grafting 2 patients. This is the bone grafting shown here. So shifting the lateral point laterally, you can get an accurate correcting of the deformity, avoidance of additional osteotomy of the femur, doesn't require a CAS or PSI. Shifting the lateral point is not been reported earlier. It is simple and reliable method, and you don't require CAS or PSIs, and decrease the incidence of inaccurate varus alignment. So conclusion that the choice of entry point is helpful in achieving the optimum post-op alignment in case of both femur. So we published in Journal of Orthoplasty this in 2017 or I think 16. So you can read this article in that. Thank you for your attention.
Neeraj?
Dheeraj is not there.
I think he must be busy. Right. Okay, so I'll start with the questions. Excellent presentation, sir. One thing, like, sir, I'm always fascinated to know whether when you operate on these type of knees, so the medial defect, now, do you prefer to put in more of wedges, or would you like to, sir, go with a screw fixation in order to pick up with use a small bone graft, a chunk of a bone graft, and take care of the medial defect? So what is the basic protocol you
Medial
follow?
defect, it depends upon the type of how big is the defect.
Right.
Suppose the defect is very small, just you undersize the tibia and end up in a screw and a cement, one thing. Or if it may not be, sometimes that is also not necessary. And
Right.
sometimes you can use a bone graft if the defect is around 10 millimeter or so.
Right.
If it's too large defect, then maybe we can go for wedges. Wedges are hardly used. Bone graft, it does well. Whenever there's a defect is there, when you do bone grafting, then always prefer to use a stem that will share the load.
I'll share the. And how early do you mobilize such patients, sir? When you've
There is
prepared?
no problem with it because we have a stem and we have a cement is there, and we have already reconstructed the defect. And if your alignment is good, and if you are not kept the knee medial tightness, I don't think to worry.
Right, right, right. Another question, sir. Now, this is again regarding the virus knee. Suppose, sir, you are inclined to do a pie crusting. I mean, in most of the cases, what we do usually. So, do you assess the MCL and then take your call, sir, whether you will be doing the pie crusting or not? And or what is the protocol you follow?
So again, yeah, the first thing is once you open the knee, you have
Right,
to see there is a knee is correctable or not.
right, right,
So if it is a correctable, then you do a tibia, then standard distal femur. Then again you assess the gap, the
right,
medial and lateral side. If it is a slight, medial tightness is there, you may not release, pie crust anything. Just need a posteromedial release, the posterior oblique ligament and deep collateral ligament.
right,
That is good enough. And still, if it is, then after doing the AP cut, then again come back and check again. The medial is still tight, and also in extension and flexion, if it tight is there, then maybe you need a pie crusting with a 80 number needle. Not, I don't use a knife.
Not done. Okay, 80 number is wooden. Right, right, sir. Right. So another one more question from my end. what would you prefer to correct these alignments? You go for the computer assisted measure or the conventional one, sir?
So actually what happened, these all methods I started, when our computer was there and it was not working, then I started doing scanograms and started analyzing these deformities.
Right.
Then I had to do conventionally, means then started thinking that way. That's how
Right.
so if I don't get, either way I can do, in the sense,
Right.
if you don't have computer, we can do this method. I'm able to get a good, reasonable, very good alignment.
Right. Well, would you prefer a conventional more, sir, compared to computer assisted?
Yes, because the long term now the results are not showing any superiority of a computer navigation over conventional. Hence, the
Right.
conventional technique is a little faster, and
Right. Right.
listen, you need to have a lot of patience with doing navigation surgery.
Right. 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 Yeah, Neeraj, your questions.
Yes. So I want to ask you two, three questions. Simple. I don't do much TKRs, but whatever I have done. So I have in the last few patients who are not happy. I want to talk about those unhappy TKRs. Both were varus knees. One of them is my aunt. She has osteoarthritis in the other knee where the pain started. I was telling you, get a TKR done. And then she got disabled and basically the other knee also started hurting a lot.
Okay.
Now she underwent a TKR that went very well. And but still she keeps on complaining of anterior knee pain. Patella was replaced in her case. She keeps on complaining of anterior knee pain. And in fact, she's saying that the other knee is fine. This knee is hurting me more nowadays.
Opposite knee
She's
is
now 5 years post TKR, and she still keeps on insisting on taking a placebo like glucosamine chondroitin every day.
means patella is replaced, right?
Yes, but in spite of that, she keeps on complaining that there is something not right in my knee. I'm not sure whether she complains of anterior knee pain, but she still says, "इसमें दुखते रहता है, दुखते रहता है."
So what exactly when she gets pain? Is it a continuous pain, or getting up, sitting position pain, or climbing down the staircase is painful? Which is
Mostly climbing down the staircase.
you are the better person to judge, and that you must be knowing intraoperatively, and you say because the climbing down the staircase either maybe uh, either anterior patellofemoral pain, or maybe the some amount of any laxity, midflexion laxity is the only concern, or these are only two reasons why she should get climbing down the pain. Uh, Otherwise, I don't think to anything. How she is mentally, like
Oh,
she is
she is not so comfortable, man. That is what I feel.
preoperatively the status of her mind before undergoing
Yeah.
surgery.
Can I share her X-ray with you? I have her X-rays right now. So maybe I'll just share her X-rays. Latest X-rays were done few months back. Let me share those with you, and maybe then you'll be able to give me a better judgment. Is there anything wrong? Can you see the X-rays now?
Yeah.
Just a minute. Let me magnify them for you. Yeah.
No, this is reasonable alignment. And she is in FFD.
See, there is a problem. I felt. What is this here?
Which one?
No, she doesn't have any FFD. She doesn't have any FFD.
This X-ray was taken AP X-ray. It was in a sort of a gap. The joint line is not very well seen. Like this, the left side, right side, it is like more of overlap. Maybe the little FFD looks like, or maybe the obliquity of the race is coming from the up. That's why we are appreciating like that. Lateral view, skyline is there, Neeraj?
No, I don't think I was taking a skyline. What is this? This is normal to see in this?
No, it is actually little overstuffing of the
Overstuffing. Yeah.
That's maybe the reason for our anterior knee pain. But if the overstuffing is there, you should get climbing up from the staircase, or maybe getting up and sitting position also should get pain.
Maybe she's getting. Don't know the exact history. I am actually this Prolia injection is due, so maybe I'll take her history and get back to you very soon.
Yeah.
I have not seen her for the last 5 months after the lockdown. But because I'm going to give the Prolia myself, so maybe that time I'll basically see it.
This is what company?
This is Max.
Max, okay. PCL retaining or what?
No, PCL substituting.
Okay, pegs are there. Okay. Also, they are Zimmer.
Yeah. This is Max. The Max imported one, not the Indian one. It was done many years back. I think it was done 5 or 6 years back. So this is one. Now I'll show you a recently. Now I'll show you a recently done knee. In that case, what had happened? He had a major FFD before the surgery. Okay, and he had this. I forgot his name. So he had a major FFD before surgery, and we could correct the FFD on table, but somehow the FFD is come back. Means not so severe, but it is there.
How
So
much is
let
the
me.
P of FFD?
Can you see the screen still, or did I stop?
Yeah,
It
it's
stopped. It stopped.
I can see this.
Just a minute. Let me show you now. Now see this. This is the one. This is the recently done me. This is you can make out. This is Attune.
Yes, correct.
Uh,
Yes, very well done, Neem. AP is fantastic.
Cement mental is also good.
Yeah, you are not replaced Petala in this case.
Yeah. Here we have not replaced Patella.
Yeah, yeah. Mean, see, in this case, you do you have any walking video or how much is the FFD is there?
So it's not so much, but he comes to me that abhi bhi thoda bahut dukte rehta hai. So this is what I have seen in my knee patients compared to hip patients. That hip patients just forget that they are anyways time operated, but knee patients na somehow they keep on coming back to me at least once a year or once in 2 years, and they complain that thoda bahut abhi bhi pain hai. Little bit pain is still there.
No, no, actually, Neeraj, what happens in these cases, no, on table, your judgment is very important. Like if you feel that little tight is there, don't come, don't, no, maybe you just take additional distal femur cut. If you feel tight is there an extension,
Hmm.
make sure that you get an extension. Especially
Hmm.
the male patients, uh, if they have preoperative deformity is around 20-30 degree or 20
Yes.
degrees there, try to get a neutral alignment.
Okay.
And post-operatively, because if they have little 5-10 degree FFD, this male patient, they don't stretch out.
Okay.
So that's how it is. Basically, that is the main thing. And they have a difficulty in walking because of a 5-10 degree FFD. That's why they
Yes.
keep complaining.
Yes.
Uh,
So this I think is basically that was the problem. He was male patient, a little heavyweight.
Obese is also.
Especially the male patients, a sort of tight knee, you feel 10-20 degree FFD itself is big enough for them.
Hmm.
So
But it's done well. The implant has come in well.
Hmm.
yeah. X-ray is fantastic. There's
Hmm.
no comment on
Okay.
it.
Okay, so I think this is from my side. Uh, uh, do you have anything else, Salim?
No, no, that's all. That's all from my side.
So thank you, Dr. Rajshekhar, for sparing your time and for giving a wonderful presentation and for clearing all those people's doubts where big surgeons always speak about navigation and robots. And you're saying that you can give equally good results now, long-term results, that is.
What happened?
Yes.
I was trained with Dr. C.J. Thakkar. He was
Yes.
the first person to
Yes. To have navigation in his, yes.
Right.
Then we started doing navigation. I used to that navigation.
Yes.
Then when he came to Bangalore, there the navigation was working, but again I was supposed to use sometimes that conventional method. Then I started doing this scanogram. Then I analyzed those patients. Of those patients are TBI and femur. There is a lot of variation was there. That's how we
Right.
was able to come to this technique.
So for surgeons like me who work in smaller hospitals all over India, and there are so many of us that who work in smaller hospitals, our own nursing homes, and
Even
they
the
don't have
scannograms
access to
are not
navigation.
possible. No, best
Yes.
just take the simple TBI, AP,
Hmm.
and
Right.
femur.
Right.
That
And
gives
so navigation is not required for at least the simple varus knees. Certainly not is what you have shown today. And we thank you very much. We thank Dr. Salim Patel and we thank Zydus for this Digitalk series and hope to see you next week again. Good night and bye-bye.
okay, bye.
Thank you, sir. Thank you.